Thank
the
you.
my first question is about the Serena 6 study. The primary results of Serena 6 study, which evaluate the novel third drug camizestrant in the first-line treatment of advanced HR-positive, HER2-negative breast cancer, were announced at this year's ASCO meeting and published in the Journal of New England Journal of Medicine. And new data from the study is announced during the ESMO Congress 2025, such as the patient-reported outcomes. So my question is, as a principal investigator of the Solana-6 study, what do you consider to be the main highlights of this study in terms of both study design and existing data?
Yeah. So I think the interesting thing about Serena 6, it really tested the hypothesis that if we intervene early in breast cancer before there is radiographic progression, what we will have benefit for the patient. That's pretty much the central idea. And so just to recap Serena 6, women starting 6 months after with metastatic hormone receptor positive breast cancer, uh, starting about 6 months after therapy with CDK4/6 and an aromatase inhibitor, began to be tested every 3 months with the Garden 360 assay for the ESR1 mutation. When they developed that, about 3,200 or 3,200 women were tested, and during this, every 3 months. And if you converted, then you had a CT scan to check to be sure you did not have metastatic progression. About half of the women did. And then of the women that were left, about 500 women qualified. For unknown reasons, about 200 women did not get randomized, but of those 500 women, 320 or so were randomized to camizestrant and to switch to camizestrant and continue the CDK4/6 inhibitor, which for the most part was palbociclib, although there were women with ribociclib and abemaciclib on the study, or to continue on their aromatase inhibitor and CDK4/6 inhibitor. And in terms of progression-free survival, it was about 16 and a half months in the camizestrant arm versus about, I think, 9 months, 9.1 months in the aromatase inhibitor arm. Now, people can argue, and they did, that all you're doing is just delaying progression and you could treat them with fulvestrant and another CDK4/6 inhibitor 8 months later. And so, really, what's the difference? I mean, there's obviously a difference in progression-free survival. But to me, the most important part of the trial, and this was expanded on at ESMO, is that the patients who remained on an aromatase inhibitor and did not switch to camizestrant had a drop in their quality of life. And that was detailed at ESMO, at the abstract that was presented at ESMO, in that it really was not arthralgia's difference in, say, side effects from the medicine. That was what everybody had concluded initially, was that they're going to camizestrant, there are fewer side effects. That's not what happened. In fact, at domains that you'd expect for someone who had progression, say pain, fatigue, dyspnea, there were clear changes and clear preservation of quality of life in the camizestrant arm, where in the aromatase inhibitor arm they decreased. And the reason for that is that generally it was a median of about 18 to 22 months where people began to be tested. It wasn't exactly when they were asymptomatic. It appears in the trial that people already began to have symptoms of clinical progression, but without the CT scan showing anything. So, in fact, it proves the point that that molecular detection of progression is probably more sensitive in helping us figure out when to change than actually using radiographic progression. I think it really supports that hypothesis. And So, in other words, I really think this is something that did deserve a plenary session at ASCO. It did deserve a New England Journal of Medicine paper. I think that this is going to be the new way, I believe, that we're going to monitor women with metastatic breast cancer in the future. Because again, women who have bone-only metastatic disease is very difficult on a scan to detect progression. Bone scans that look like progression, can also look like stable disease, and we have this concern all the time in metastatic breast cancer. So I think that you know both the original presentation at ASCO as well as the supportive data discussing the quality of life changes really do support this hypothesis. Whether the US FDA approves the drug or not on this basis is still an open question. We hope it does, and we're still waiting for that decision to be made.
Yeah, so congratulations on your successful clinical trial. I think it's a paradigm from the precision diagnosis to precision medicine, right? So
Yes.
what immediate impact does it on your clinical practice?
For now, nothing because we can't get the drug is not approved. However, I think what will happen in the not too distant future is that if it is approved in my practice, when women begin to have, we do this anyway in clinical practice as right now, that when women begin to feel symptoms of progression, say they have oligometastasis, one bone met that's larger, we radiate that bone metastasis, and I will start to do ESR1 testing. If someone does convert to ESR mutation, I'll either place them on fulvestrant or use an oral SERD at that point. The ones that are approved in the United States include elacestrant and now imlunestrant. So I'll do that. So in my clinical practice, I've been doing that anyway before this trial even started. I think a lot of us were doing that to begin with. This just supports that clinical change a little bit more. I will not start testing people when they're asymptomatic. I will wait until this is almost the art of medicine. I'll wait until I think somebody, have been on their CDK4/6 inhibitor 18 months, 20 months, and they begin to show signs, just clinical symptoms of progression. At that point, I will start ESR1 testing. Even though we don't have camizestrant available, I'll use fulvestrant instead of camizestrant until camizestrant is approved. So that's how I am going to do this going forward.
Yeah, and I'm also a clinician and treat breast cancer patients. So the earlier approval and the earlier access for our patients. So could you please, maybe it's not, this question is not related to this topic. Could you please predict the process of regulatory approvals in different country and updates in relevant guidelines such as ANCC guidelines and ESMO guidelines?
Sure. I think that since camizestrant is a new drug, generally in NCCN and ESMO, they won't, and ASCO guidelines, they won't put it in the guidelines until it at least has FDA approval. I think that that's number one. So it's going to need FDA approval, and we're going to have to wait for that. I think once that occurs, I think most of the guidelines committees will likely place this in their guidelines at some sort of ESR testing um, at some point. I think it's really going to be open. When you ESR test, I think is going to be left to the discretion of the physician. But I do think this will become part of the guidelines. But it needs FDA and EMA approval first. And I think that's what we're waiting for. This is a novel regulatory pathway for the US FDA to approve, a drug on the basis of molecular progression as opposed to a clinical progression. Now, I know in China, there are certain I think in China, there have been certain drugs that have been approved now through the Chinese regulators based on molecular progression. And we're just starting to do that in the West. I hope that happens because I really am starting to believe that molecular progression in certain tumors, not all, but I think at least in certain solid tumors, radiographic progression can be difficult to see. And I think we do need more sensitive ways of doing this. I do believe that the regulatory authorities and the guidelines committees will likely adopt this. When, I can't tell you, but I believe they will in the not too distant future.
Okay. Now, as you mentioned, the Solana-6 study used the circulating tumor DNA testing to assess patient ESR1 mutation status and adjust the patient's treatment regimen to camizestrant plus CDK4/6 inhibitor combination therapy before there was evidence of disease progression. So, what advantages do you see in use ctDNA test results to guide treatment selection in clinical practice? And what are the challenges?
Yeah, so the challenges are the cost. These tests are not inexpensive. Two, I think it's adopting it as part of the workflow of a practice. I think people have to remember to do the tests. I think we'll probably end up doing them as part of regular CT scanning, or what we'll do is we will maybe do in between. Maybe we'll do a scan instead of every 3 to 4 months, every 6 months, but do a ctDNA in between every 3 months. I think we still have to figure out the timing of the ctDNA. That's another barrier to adoption. But I think that uh, this is the future in certain solid tumors because I think we're learning the advantages of doing it are seen in Serena 6. In other words, people are having clinical symptoms from their cancer, but we're not switching their therapy, even though we know they're having symptoms and their quality of life is declining. And I think the advantage of early intervention is potentially to prevent that quality of life decline. That's kind of what we want to do with more sensitive testing. And it may not necessarily be, I think there's a whole, it's in other tumors right now, but I think it'll be in breast in the not too distant future where people are looking at levels of ctDNA, not necessarily the composition, not necessarily the ESR mutation, but levels of circulating tumor DNA, which you can get at a much lower allele frequency than you can for actually sequencing mutations. So I believe that is likely going to be the way. Uh, in the not too distant future, it may not be next year, but within the next several years, I think we are going to move in oncology towards ctDNA detection. Now, the other disadvantage, it may be too sensitive, that there may be patients who have circulating DNA going up but really don't have any symptoms. Again, I think that it's really going to be a clinical judgment in a lot of cases. It's just a new tool we have. Like any new tool, you still have to use your own clinical judgment as a physician to determine whether to use it and act on it or not.
Uh, the next question is, if Solana 4, the trial, is also positive, would you still consider periodic ctDNA
Yeah,
testing? Or,
that's a good question because then if Serena 4 is positive, Serena 4 obviously is the first line camizestrant CD. So the hope is that the oral SERDs in Serena 4 will do better than fulvestrant. We don't know if that's the case. Let's assume that it is. If it is positive, then there really won't be a reason to use ctDNA testing for ESR1 because we're already using the oral SERD to begin with. I think then the question becomes should we be using it for other reasons? In other words, someone maybe not necessarily getting ESR1, but maybe getting just ctDNA in general. And if levels of ctDNA go up, then maybe make a therapy change, to the next line of whatever that could be. PI3 kinase inhibitor, it could be, maybe gelidolosib, whatever new CDK4 new drugs we have in the second and third line. I think that maybe that's how we'll end up using ctDNA. We won't use it for ESR1, but we'll actually just use it as levels of ctDNA in a patient that has symptomatic progression without obvious scan changes. I think that's how we're going to use it going forward if Serena 4 is approved. But we'll have to see. I don't think we have the data yet for Serena 4. And again, I'm a little concerned about the use of oral SERDs as first line therapy based on the Parsifal data that we've seen so far.
And next question is about the quality of life. And in the past, in which specific domains was the deterioration of quality of life primarily seen in advanced HR-positive, HER2-negative breast cancer patients receiving treatment? Was the anti-cancer therapy the main cause of this deterioration?
It was not. And if you look at the data that was presented at ESMO, there was a very nice table toward the end of the presentation where they asked the patients if the patient-related outcome, did the therapy cause these changes? Did you feel like it was therapy? And most patients said no, there was no difference in that. There was no difference in arthralgias, which is the biggest difference between the two. Most of the differences were in cancer-related domains, shortness of breath, pain, fatigue. Those are not what you'd expect from the change in therapy. They're what you'd expect from a progressive cancer. So I feel pretty strongly that the differences that we're seeing were really from cancer progression, and you were delaying symptomatic progression in Serena 6 by early intervention with an oral SERD.
Yeah, I totally agree with you. The PRO's data from the Serena 6 study released in this conference showing that the camizestrant plus CDK4/6 inhibitor combination therapy can significantly reduce the risk of the deterioration in patients' overall quality of life and certain functions. To what extent do you think these quality of life benefits will influence your daily clinical decision making?
I will treat earlier based on this. I think that we in the United States and in the West, we've kind of done that already. I believe you probably do it in China as well. That I think people who, even though the scans may look the same, generally, if someone is having symptomatic progression, some of us tend to change early. And what I always tell patients, I look for three things. I look for symptoms, scans changing, and marker elevation. If they're all going in the same direction, I tend to switch therapy. Now this is just another, instead of using a protein tumor marker, say CA2729 or CEA or CA15-3, I think we now have a more sensitive marker to help us out with the circulating tumor DNA. And for me, if someone does have symptomatic progression, and maybe their scans are the same or stable, I think I will start to use ctDNA to help me make those decisions. We don't have a lot of data. We're still developing the data for breast cancer. We do have it in other tumors. But I still think that this will probably influence my practice. It already has started to.
很高兴今天呢，这个 Professor Brufsky 呢接受了我们的采访。我觉得这个 Solana Six 呢，它是一个成功的范例。这个成功的范例是从精准的诊断啊，得到精准的治疗。那么我们检测到了在血的 ctDNA 当中检测到了这个 ESR1 mutation。那么我们理论上用 ESR1 mutation 的抑制剂，那么就能够改变病人的结果。那么我觉得这是一个很成功、非常成功的范例。但是呢，就是说 Brufsky 呢，他也讲了，现在还是一个最主要的限制它的运用还是一个费用问题。那我觉得这也是可能在中国还是相同情况，我们要连续的每2到3个月检测。那我晓得，真的如果在临床上碰到那些病人不差钱的，他希望更好的生活质量，生活质量不受到影响，在这整个 Surround Six 里面，病人的生活质量最主要的得到改善，不是这个药物相关的这些这个治疗相关的一些 AE，而是这个肿瘤相关的。所以控制这个肿瘤的这个疾病进展时间，也就 PFS 越长越好，病人的生活质量越得到改善。所以我们也当然他也特别谈到了我们另外一个临床试验叫 Solana Four。那么这个临床试验呢，它是在一线治疗当中呢， 这个做的。那么这一些治疗的时候呢，他说，哎呀，你已经用了这个ER31突变的抑制剂，可能在检测，可能 ctDNA 检测 ER31的突变可能就没有意义，但是在其他的方面，包括 ctDNA 的定量，包括有其他的 marker 可能检测对我们的临床决策，当然这有待于将来进一步的研究。那么，能够可能能延长病人的 PFS 时间。当然，就是说 s o r a n a six 这样的一个成功的范例，从精准诊断到精准治疗，给了我们一个中国的医生，我想更多的学习一个机会，怎么样的去设计一些转化的研究，让病人呢从这个去最新的这个诊断手段最新的这个治疗当中获益。那以上呢就是我的今天我们讲课的这个一些总结。